working on backup plans to get some coffee.
Oh, okay.
Whoever was supposed to do it failed and is in trouble with me. I don't know which, if anybody sitting in the back row was responsible for breakfast this morning. I'm not happy with it.
Go away. What are the days? Endotype?
Okay, so this is the big day. It's been a bloody and ugly journal club session up to this point. But our candidate is here. Probably most people are watching the football game and not watching the election anymore. Anyway, so Andrew's going to do, I'm not sure if this is the title exactly that I gave you, but it looks like a good choice. Severe asthma and biologics, and review and update. Andrew, for anybody on the outside who doesn't know, is one of our 2 second-year fellows.
Good morning. I was charged with doing the annual update about asthma biologics, and so I did take a little bit of license and decided to review a little bit about severe asthma as part of the review. I have no conflicts of interest. Just a quick outline. I'll spend a little bit of time discussing some asthma phenotypes and endotypes as well as markers of those endotypes, and then we'll get on with speaking about the different therapeutics that are either available or hopefully coming available in the near future. So, from medical school and throughout general medical training, asthma is sort of taught as though it's this monolithic disease. It's just sort of wheezing and reversible airway obstruction, and sort of it's easy to treat. You have your step therapy, and you sort of go up or down as you need, and you blow steroids and albuterol in people's faces, or you give them leukotriene receptor antagonists, and things work out. And for specialists who take care of asthma all the time, I think maybe that's true in 90-95%, but there's definitely 5 to 10% of people who are more severe than that. And I think as asthma specialists, we sort of understand that there's more of a nuanced picture there. We see different types of asthma. That's why people come to us. For a long time, we've been able to identify those who have different types of asthma, atopic versus intrinsic, or non-atopic asthma, using skin testing or IgE testing. And we've been able to treat that a little bit differently than the general provider. We have additional things like immunotherapy that can treat atopic phenotypes. We see childhood versus adult onset, which probably plays into the atopic and the non-atopic. And we see other types of phenotypes like exercise-induced bronchoconstriction and aspirin-exacerbated respiratory disease. I think, so back in the early 2000s, the NHLBI sort of realized that there was this 5 or 10% too, and they wanted to look into them a little bit more. So they created a Severe Asthma Research Program, SARP for short, to try to figure out the differences between those with sort of mild, moderate phenotypes and those with more severe phenotypes. Prior to this, there was sort of a priori definitions of asthma severity. There was the mild, we still use them today, the mild intermittent, the mild persistent, etc. And those were sort of, they came up with, criteria for each of them, and you sort of move down, and you get a point for each, and you fall into a category. But it wasn't really clear where asthmatics sorted themselves out. And so one of the earlier things to come out of this was a cluster analysis. There's actually a few of them, looking at the SARP cohort. And this was a cohort of adolescents and adults. About half of them were mild to moderate asthma, and half of them were more severe. And they looked at 34 clinical variables. And actually, the cluster the cohort, sort of sorted itself out into about 5 clusters. Cluster 1 were younger patients with childhood onset atopic asthma that really weren't requiring very much intervention at all. Cluster 2, which made up the bulk of it, is probably the people that are seen in the majority of clinics, and these were maybe older also childhood onset adolescents or young adults with sort of regular medication use. When I say greater medication use, greater than cluster 1, but not huge amounts. Clusters 2 is somewhat related to cluster 4, and that cluster 4 is also older atopic asthma, but it's a little bit more severe. People are requiring multiple meds for control, and even that's really not cutting it, and they're having a lot more presentations in the healthcare setting because of their asthma. Cluster 3 and 5 are similarly related. Cluster 3 is this cluster of older females with sort of late onset non-atopic asthma. They tend to have higher BMIs with baseline obstruction, and they require multiple meds for control, many of whom requiring steroids. And cluster 5 is that same sort of group, except despite all their multiple meds and despite their steroids, they still don't have very good control. And they're the ones who are in the emergency room all the time. As I mentioned, there was a few of these cluster analyses done, and they came out with similar results. And I think it boils down to what we see is that early asthma is typically atopic, and late onset asthma is typically non-allergic, and can have other features like worse airflow obstruction and resistance to treatment. So when I say phenotype, what exactly do I mean? Well, a phenotype, like in genetics, is sort of the outward appearance of sort of whatever's going on underneath the hood. And endotype is what's going on underneath the hood. It's the pathophysiologic basis for the phenotype that you're seeing. And there's been a push in asthma over the last several years to sort of identify these endotypes as a means to explaining the phenotypes. By sort of understanding this pathophysiologic basis, it helps to elucidate the phenotypes, as I mentioned. It gives us the ability, or helps us to identify markers of these phenotypes. And with hope, they'll give us some novel mechanisms in order to interrupt the asthma that thus far has been difficult to treat in some cases. So this is the pathophysiologic or immunologic basis for allergic asthma. And the point of this slide, I'm not going into explaining this to you, and it's not for you to necessarily understand, but I think what you can appreciate from it is that there's a number of pathways that are really interlinked. And you can see these pathways that they're in black. And each red line is sort of an opportunity to interrupt those pathways. And as you can see in the red boxes, there's names of therapies that are either available or are may become available or under evaluation. And so there's a lot of opportunities to interrupt this asthma cascade. And it'll, I guess, just depend a little bit on which ones seem to work and which cascades seem to be the most important. The phenotypes that we've frequently recognized, or have recognized for a while, that sort of allergic and non-allergic, has sort of translated into these endotypes, known as T2 low and T2 high. A little bit of a word about the nomenclature. So for a long time we've mentioned sort of TH2 high, TH2 low. And with the advent of when we found innate lymphoid cells back in 2013, I think that in the more recent literature, the nomenclature's changed a little bit. And there's innate lymphoid cells are cells of lymphoid lineage that don't have T and B cell receptors on them, but still make a lot of the same cytokines that T helper cells do. And so there's been sort of a broadening of the terminology. So T2 low, non-atopic, is asthma with more of a neutrophilic or polygranulocytic profile. It is characterized by elevations in IL-8 and 17 and 23, and can be more resistant to steroids. This is about the end of T2 low asthma that I'm talking about today, because unfortunately, as we all know, there's not a lot of interventions there that have been successful to this to date. T2 high atopic asthma is much more of an eosinophilic profile, although there's plenty of mast cells and NK cells and Th2 cells hanging around. It's characterized by ILs 4, 5, and 31, and typically has a much better response to steroids, typically. So I work really well with frameworks. I like things to be sort of cut and dry in one way or the other as sort of a method of thinking about things. I found this image which helped me to sort of break things down a little bit. So you have your asthma, and it sort of breaks down into Th2 low or T2 high with the neutrophilic and polygranulocytic profiles. And then for T2 high, you have sort of perturbations in eosinophils and or you can see elevations in IgE, eosinophils, or prostaglandin D2. This image is a little bit misleading in that this sort of suggests that you can have one or the other, like you're going down a pathway, and I don't think that's necessarily the case, although it can be. Practically, in some of the severe asthmatics that we see in clinic, you can have those that have only elevated IgE, but they don't have much of an eosinophil count, or vice versa. So these aren't exactly mutually exclusive. Something to keep. So how do you identify these endotypes? The reality is that there's no single or perfect marker of T2 high asthma. Earlier there was a handful of studies that was sort of folded into a Cochrane review that showed the frequency of exacerbations was decreased when ICS therapy was tailored to sputum eosinophil levels. There's been plenty of studies along the way to show that sputum eosinophils are associated with worse airflow obstruction, progressive asthma over time, and as we'll talk about, response to IL-5 therapy. But the reality is that sputum eosinophils are not that easy to evaluate, especially in clinic. It's kind of a pain in the neck, inducing sputum on people, staining it, sort of enumerating these things. And so having additional markers is really important. So what has been considered for markers of this T2 high inflammation? Well, peripheral eosinophils are one. They seem to have a moderate accuracy in identifying sputum eosinophilia. But besides that, they seem to be a good predictor of response to IL-5 agents. We've used IgE for a while, both total and sort of IgE specific to allergens. Seems to be a reasonably good marker. The fractionally exhaled nitric oxide, it is another one that we sometimes use in clinic. It seems to correlate with this T2 inflammation in response to steroids. Though it's not perfect, there are a number of factors, medication, smoking, technique, which all can change the result. And there's periostin, which has been evaluated more recently. Periostin is an extracellular membrane protein whose expression is sort of induced by the IL-4 or IL-13 pathways. There's been studies that look at bronchial epithelial cell biopsies from asthmatics and non-asthmatics, and it seems to be increased at baseline in the asthmatic cell biopsies compared to the normal controls. Regardless, it seems, some studies have shown to be a better predictor of area eosinophil than peripheral eos or pheno. The reality is that none of these are perfect markers. A recent systematic review, which used sputum eosinophilia as the gold standard and looked at peripheral eosinophils, IgE, and pheno against induced sputums, BALs, or endobronchial biopsies, thought that all of these markers were of moderate diagnostic accuracy in finding sputum eosinophilia. Sensitivity about 65 to 70%, and specificity of about 70 to 75%. But the question, I guess, becomes is, well, even if they're not, it's two-part, even if they're not great markers of sputum eosinophilia, can they still have clinical utility? Do they still predict response to treatment, which is, I guess, what we're probably most worried about? And I guess the side question is, and I was talking to Teal about this yesterday, is, I don't know, should sputum eosinophilia be the gold standard that we're measuring everything against? I don't know if that's the perfect marker or the best marker that we have of T2 high asthma. I think regardless, there's more to come. Other markers have been proposed and are being evaluated, like DPP4 and sputum IL13. I'm not getting into any of them. But be aware that you may hear more about it. So I think the theme going forward, as we sort of talk about specific agents, is that with these new biologics, the choice of a specific agent is really based on an underlying endotype being present in that specific patient. And in order to identify that, you really have to have the markers of that endotype available. And this is sort of the epitome of what personalized medicine that's been like the buzzword for the last few years. You know, if all asthma is not the same, then you got to find, look at your patient, find out what specific asthma they have, and go after treating that one, sort of, right at the source. All right, so here's this framework. I've overlaid the different medications that are sort of being talked most about at this point. Some of them are available, some of them are not. And I figure we can start with IgE, since everybody's probably most familiar with that.
Andrew, I hate to do this to you, but
Want to get some breakfast?
I'm going to ask you to stop for 1 second, maybe when he wants to get a cup of coffee. I will. While we're doing that, from a practical sense, pheno is the easiest and fastest way to do any of these things. So I've come to put a lot of stock in pheno because we can do it very quickly, and the pay rate has gotten better for it. I wonder other people's opinion, how many are doing it. Why are we not doing it in allergy clinic at the university here?
We've got an order in.
It has to go through the state government to get it approved.
Yes.
Teal, you made some comments about it last week.
Oh, yeah. I mean, I think the problem with E&O is that there's a lot of population overlap. So if you look at it like there's a review from a couple years ago in the Blue Journal that kind of really teases that out. So it's not by itself a great test, but I kind of agree that within the right clinical context, it's very useful, especially for highly subspecialty asthma, where you're reaching for some of these things that you can't do directly, such as sputum eosinophils. So,
I mean, Drew did a nice little piece of work that showed an amazingly good indicator of steroid, the right steroid dose and compliance with steroid. Nothing makes it go down better than inhaled steroids.
Yeah, I mean, unfortunately, the initial couple, the Robin Taylor papers, look, beautiful as far as being able to predict steroid response and so forth. And then there's been some other papers that didn't look quite as good. So, interesting. Yeah, we tried to get a machine for the PFT lab, and it was turned down multiple times by our department, saying that they couldn't get reimbursement and so forth. So we haven't had it, but apparently Bill is much more powerful than me. So we're going to get that over at U.
We have it in all our offices now. I think it's getting more widely used.
Yeah. Well, I think, sometimes if you have someone whose lung functions are sort of borderline normal, like, they're like 79, 80, and then you get a pheno of 120, you're like, oh, you need to go on inhaled steroids. Whereas if their pheno is like 20, then you're like, yeah, I don't know. We'll see. They might be asthma. I personally, I love it.
Some of the scenarios you gave last week of people basically with normal pulmonary function and a soft history.
Yeah.
It's great when you see
if it's very high. It's helpful.
And it's nice to have them come back in a month or 6 weeks after they've been on whatever, and then you see that it drops from 100 down to 25. You're just like, or 20. You're just like, wow.
Right.
And then the patient's like, I feel so much better, and you're like, yeah, wow.
Well, it's useful for chronic cough, too.
Yeah.
Right.
You don't have a lot of other...
Well, one other thing I don't want to disrupt your talk that I just thought I'd comment on is that the reason you don't do sputum eosinophils in the clinic is that you have to use a mucolytic to get an accurate sputum eosinophil count. And the lab at the U doesn't want to do that because it takes, processing for a long period of time. And I don't know, do you guys do that in the office at all? Because, you literally have to have...
I have a couple times.
Yeah.
We have it in asthma.
We've done it as part of research.
Right, for research, right? You have to...
It takes a good 2 hours to do it right.
Yeah, right. You use
work.
a DTT to break up the mucin and then spin it out and stuff like that. So but it would be great,
Yes.
The Graham Nair, who we've had multiple years, that I've invited to come a little later in the year, and he makes it sound like it's the same as doing a CBC, or it's just part of routine workups at McMaster. But practically, it's hard to do.
Well, I agree with that. It's not any harder in the lab to do that than to do lots of other tests that it's just not the I guess the willpower to do that in our lab is not there so far. So
If you're doing it in bulk, you can run a lot of samples together. So
Yeah.
if you have a lot of business like they do at McMaster's, it makes sense. But if you're just doing it here or there, it's
Right.
difficult.
I'll let you get back on track.
All right. So, one of the first the first biologic tool available for allergists and pulmonologists is omalizumab, and know it or not, it sort of required and it still requires the sort of consideration of an underlying endotype based on its indications. You're selecting people with moderate to severe asthma. People have to have, patients have to have an elevated IgE. And evidence of sensitization to a perennial aeroallergen. And as just a note, as part of this update, it's been approved now in children 6 years of age and older as of July. But it has a good track record. There was a 2014 Cochrane review of about 25 trials. It was a little bit weighted towards adults, but it did show a good decreased risk of asthma exacerbation, decreased risk of hospitalization, and the ability to decrease steroid dose, inhaled steroid dose. But aside from those mentioned before, just elevated IgE and stuff, there have been other predictors of response to omalizumab. In a 2013 trial, they took people who were eligible for omalizumab and then sorted them by eosinophil count. And the data's not great because the study was underpowered, and so it didn't actually come out with a significant difference. But there really was a significant trend of those with higher eosinophil counts, greater than 300, of having a much better response to omalizumab than patients with eosinophil counts of less than 300, despite them having IgE levels in the range, etc.
I was just going to ask, do you know what the mean IgE was?
I don't know.
I mean, because it's like, because you could argue if it was significantly high, are these really great markers, or are they just a surrogate for that? You know what I mean? In other words, if people have eosinophilic-driven non-IgE disease, that may not be true.
It may not be the best.
It might be a good marker.
There was, in 2013, they came out with some data. It was a reevaluation of the extra trial data. And what they looked at was that they looked at some of the biomarkers used. So on the left here, this is the percent reduction in the rate of asthma exacerbations, and along the top is pheno, eosinophils, and periostin. And they split the study group into sort of high and low, which they chose as pheno as high being pheno greater than 19.5, eosinophils peripherally greater than 260, and periostin greater than 50. And what they showed is that the percent reduction in asthma exacerbations in the high biomarker groups, especially pheno and eosinophils, was significantly more reduced than it was in the low biomarker group. And again, I don't think it tells me here what the mean IgE was. But this was one of the trials that they used for for Xolair. So it was the typical population that we considered. Earlier studies showed that baseline lung obstruction and emergency treatment in the past year, high-dose ICS were all markers of response. Although I frankly didn't get too far into this, interpreting this study, but to me those are the same people that you're going to put on Xolair in the first place. So yeah. I don't exactly know if that's all. In non-atopic asthma, there's actually been a few. There's been a few trials. I think about 3 of them in non-atopic asthma. And it fares actually better than you think it does. They have, there's again, much like in the nose, there's this thought that there may be local IgE production in the lung that you're not seeing in the blood. And people, they were sort of minimally significant or sort of trended towards improvements in FEV1 as well as decreased exacerbation rate. So there may be some promise there. I think they keep. As you can imagine, all the studies end with the line that they need more studies, but I'm not sure there's been any more since 2014. I don't want to get too far into other conditions. We know that omalizumab works well in chronic urticaria, and it's been evaluated in a number of other conditions. eczema, APA, food allergy, idiopathic anaphylaxis. And and it's hard to generalize the results. I think there's either mixed results or nuanced results within each of those. But it's definitely there's definitely some possibility of anti-IgE therapy, working in other allergic conditions. So where's the future? There's two products that have been evaluated more recently. One is Biologics. It is a monoclonal antibody against membrane-bound IgE. So unlike Mepolizumab, it's not going after the free-floating IgE. And by binding to these to the IgE that's attached to B cells and memory B cells, it actually induces them to sort of apoptose and clear. And there's been two recently released studies in this year which do show good reductions in IgE, but unfortunately, at least in this one, there was no real improvement in the sort of the clinical markers. There was no reduction in exacerbations. And furthermore, they did one in chronic urticaria that didn't show much benefit either. The second agent, Ligelizumab, goes after free IgE like Mepolizumab does. It just has a greater affinity for IgE. And so the studies to date have mostly been trying to evaluate whether that pharmacodynamic difference, whether having stronger affinity for IgE results in an actual clinical difference. And so there have been two studies. One with just skin testing that showed that Ligelizumab actually suppresses skin test wheals to a greater extent than Mepolizumab. And another one where people were challenged in an inhalational chamber, and it showed that their FEV1 reduction while on Ligelizumab was attenuated as compared to those on Mepolizumab. So we see.
Are either of those on track to be commercialized?
I think the Ligelizumab, there's talk about looking at sort of more clinical trials, looking at its actual use in asthma. I'm not sure with the database, the Mepolizumab data, that it's going to go anywhere. I'm not sure. All right, next, IL-5. So IL-5 is a cytokine that's secreted by Th2 cells, and it really it stimulates the growth and differentiation of eosinophils, and then causes them to migrate to areas of inflammation. In the case of asthma, the airways. And Mepolizumab has this sort of storied past where in the first evaluations in early 2000s, while it showed definitely a decrease in sputum and peripheral eosinophilia in unselected asthma populations, there was not that much clinical benefit found. And it wasn't until later, in 2009, where a clinical benefit from reductions in sputum and peripheral eosinophils was identified in a population of eosinophilic asthmatics. So you really had to choose the right population to see an effect. The DREAM trial in 2012 required sputum or peripheral eosinophilia, or they allowed a FeNO greater than 50. And interestingly, whether MEPO worked or not aside, it showed that baseline FeNO levels were less associated with the Mepolizumab response than peripheral eosinophils were. So that really became so eosinophils really became the marker that to look at for consideration of Mepolizumab. And these are just a table with the trials. The three big ones, DREAM, MENSA, and SIRIUS, for those that like the cardiology style names, are all there. And both DREAM and MENSA showed that in eosinophilic asthmatics that there was a very good reduction in exacerbations. And then the SIRIUS trial later on showed that that Mepolizumab offered a steroid-sparing effect in addition to reductions in exacerbations. So it was approved last year. And unlike Mepolizumab, which has very specific criteria in who to use it in, the FDA just said you can use it in eosinophilic asthma. But they didn't really specify what that meant or how to determine that. So there's been, there's data obviously from the initial trials which show that peripheral eosinophilia greater than 150 is sort of around the baseline that you need to see a benefit. Although I have some data here. So this was a study this year that reanalyzed the DREAM and the Mensa data. So I think it's most worthwhile to look at this last column over here. This is the Mepolizumab, combined Mepolizumab cohort. And what they looked at here was, on this side, they sorted everybody out by their peripheral eosinophil count. So this is greater than 150, greater than 300, 400, 500. And what you can see is as you go up in eosinophil count, so those with at least an eosinophil count of 150 peripherally had a 52% reduction in their rate of asthma exacerbations. But as their peripheral eosinophil levels go up, the mouse go, you can see that the reduction in exacerbations, improves from there. So that by the time you have greater than 500 eosinophils peripherally, those folks were basically having a third of the exacerbations as the placebo groups. So how well does it work? There's a good amount of data at this point. There was a meta-analysis from 2013 that showed a reduced risk of exacerbations and improved quality of life. But the data for improvements in FEV1 are more limited. I'll discuss that a little bit more in a bit. There was a recently released long-term safety trial that was done this past year, which showed that even the long-term mepolizumab continues to offer reductions in exacerbations, and there was no newly identified adverse events from long-term use. So Reslizumab is the second anti-IL-5 agent available, and there's been 4 sort of big trials that I'll report here. The first was in 2011, and this was in folks with sputum eosinophils greater than 3% that were not controlled on ICS. And use of Reslizumab reduced their sputum eosinophil count, improved their lung function, although it sounds like the symptom scores that were done as part of the study were not significantly different. But in 2015, there were replicate studies done with a total of about 950 subjects. These were adolescents and adults who had to have a peripheral eosinophil count of at least 400. And they got Reslizumab monthly for a year. And they showed a nice decrease in exacerbations between both study groups, as well as an increase in FEV1 by just after the first month of therapy, with improved quality of life indicators. It's pretty well tolerated compared to placebo. The only real difference was there was 2 episodes of anaphylaxis in the active group, and that remains on the label. All right, so there's a study from this past year, which was kind of interesting. It used Reslizumab in all comers with asthma, so not necessarily eosinophilic asthma. These were all adults. It was about 500. And the actual cohort had about 20% who had eosinophils greater than 400. And unfortunately, overall, there was really no significant improvements in FEV1 and FVC and all these parameters, albuterol use between Reslizumab and placebo in this all-comer group. In the subgroup with those of greater than 400, there was sort of a trend towards improvement, although the study wasn't powered to show a difference there. So, to sort of sum up our current anti-IL-5 therapy, we have 2 agents available, both of them with good effect in eosinophilic asthma. The indications and the administrations vary slightly. It seems as though, at least based on the information we have to date, the necessary level of eosinophilia seems to vary a little bit by product. I'm not sure if that's just a manifestation of the way the studies were done, or if there is some slight difference there. I think regardless, though, the higher the level of eosinophilia, the better the response you're going to see from either agent. And I think that's what we see in clinic. I was talking to Drew as I was preparing this about who we actually are able to get on anti-IL-5 therapy at the U, and it sounds like, Drew, you've only had luck in getting people with eosinophil counts greater than 500 or above 500.
One I've gotten approved below that, but yeah, I don't know about other people's experience with it. But 500 seems to be the cutoff for what the insurance companies will approve.
No, it's been easier in private practice.
Yeah.
I think we've had people at 150.
Really, I haven't been able.
I haven't put anybody on Reslizumab, only Mepolizumab. Part of the problem is it's IV. It's not easy to do. But
And anaphylaxis risk, which isn't seen in Mepolizumab.
a digression. I should have asked this question before. We just recently had a reaction to Xolair. And I had basically given up that anybody had those reactions and was getting very cavalier about it. This person had 15 injections. And you have anybody else in the community having reactions to Xolair?
We've had a couple over the years.
Yeah.
I had one a couple months ago.
So
Very first
have you ever
patient.
re-administered the drug, or you gave up on it?
No, I just gave it again, and she did fine.
That's my experience too. The very
Yes.
first patient I started on it called me up the next day, said she had hives, obviously not anaphylaxis. I said, you can't be allergic to stuff if you've just never seen it before. Gave the next dose, no problem.
Okay, that's encouraging to hear. The company's literature is pretty scant. They say they have 27 reports and that were re-administered, and 18 had the same reaction again, which sounds like you wouldn't want to do it, but this woman wants to stay on it. Anyway, I'm sorry to make it digress.
Andrew, any studies with the COPD overlap asthma group or COPD with Mepolizumab? Or?
I don't look at specifically. I think there was a study ongoing with Mepolizumab in the COPD, but I don't know if the results are out yet.
Actually, I just reviewed it last night, and it doesn't work. So they knocked down sputum and blood eosinophil counts, but it had no clinical or any other positive outcome. I'm not exactly sure. Maybe Teal, though. I don't exactly know why 30% of what you would define as COPD have eosinophilic sputum, and how that's a different disease than asthma, other than they smoke. I find that very confusing.
I think that's the key.
Yeah, I mean, that's a whole big topic, but I don't really think that there's so much of a kind of overlap syndrome, other than that you have two highly prevalent diseases that occur at the same time relatively frequently. So, yeah. Anyway.
Yeah, there was an article in the New England Journal, about a year ago, about that, and it seemed like ho-hum. It really didn't say anything.
Yeah, like that idea of the overlap syndrome kind of waxes and wanes over time. So,
I think both products, they seem to, the data shows they reduce exacerbations well. There are variable improvements in FEV1. Mepolizumab has not had robust data showing improvements, although Mensa did show some small improvements. But a lot of the trials also did not exclude people with fixed obstruction, so I'm not sure they should be expected to necessarily improve their fixed obstruction. Improvements, though, were more consistent with Reslizumab, though they weren't seen in this Corin study, but then the Corin study was not the typical population that we use it in. So I think overall, most of us who use these agents assume they're probably reasonably equivalent in terms of their efficacy and base their decisions on use on other factors. So where are we going with IL-5? Benralizumab is an IL-5 receptor antagonist, and it is basically it goes after the IL-5 receptors that are on eosinophils and basophils and causes clearance by antibody-dependent cell-mediated cytotoxicity. So basically, on the other end, on the side that's not attaching to IL-5 receptor, it basically causes IgG to attach to it, and then the whole sort of NK cells come by and clear them out. And that seems to even this apoptosis seems to occur even with a single dose of benralizumab. In 2014, results of a dose-finding study were released. These were patients with both eosinophilic and non-eosinophilic asthma. They basically received benralizumab monthly for the first 3 months, then every 8 months, and they showed a good decrease in exacerbations and an improvement in FEV1. was also well tolerated except for nasopharyngitis, which occurred more often in the intervention group. This past year, phase 3 data came out for adolescents and adults on 2 controller medicines with 2 exacerbations in the last year. They had to have a baseline peripheral eosinophil count of 300, and they received it either monthly or monthly for the first 3 months, then every 8 weeks, or placebo, and they also had reductions in their exacerbation rates, improvements in FEV1 and symptom scores. This 2015 study was kind of interesting. This was a trial in the ED. The study, there's been data before this that shows that people who show up at the ED with an asthma exacerbation, they have about a 50% chance of showing up again in the next 12 weeks. So these investigators thought, what if we treat them for their acute exacerbation, as we do, but then also give them a dose of benralizumab while they're there and see what happens 12 weeks out. Now, they took all comers. They didn't sort them by eosinophil count, and they actually were going to, in the final analysis, look by eosinophil count. But I think there were some questions. They realized afterwards that a lot of people receive steroids from from whoever treats their asthma prior to them getting to the ED, so they weren't confident in whatever eosinophil levels they saw. But what they saw was interesting. So the number of actual subjects who returned with at least one exacerbation in the subsequent 12 weeks was not different between benralizumab or placebo. But the number of exacerbations that people presented with was less in the intervention group. So if you were on placebo, these people re-showed up to the ED about 3.6 times in the following 12 weeks. Whereas people on who received the 1 dose of benralizumab only returned about 1.8 times. The rate of hospitalizations in the benralizumab group also was decreased by 60%, and they used that for a surrogate for severity, and they thought that they were basically returning with less severe exacerbations than in the intervention. So, kind of an interesting study, and something that it's not a typical use of biologics that we typically think of. We don't think of them as one-time use agents.
Since they seemed like it induced a nice reduction in the cell numbers after single dose, did they follow how long it took to recover the eosinophil levels after that? Could you have a really extended length of treatment? I mean, every 3 to 4 months?
We're talking about in general or with this specific
With this agent here. It sounded like the single dose was quite...
Yeah, the single dose was effective. I don't know how long it... I don't know... After the 12 weeks, they stopped looking. They only followed them for 12 weeks, so I'm not sure we know how long the effect went out for, is my understanding.
And also, since the basophil levels went down, did they have any comment on potential effects on mast cells? Maybe mast cells would be implicated in this treatment, too.
I don't know about mast cells. I did not see that. I don't remember it, at least.
Just shows it could have multiple different effects. It could be quite potent.
It could be, yes. I think that they saw the percent reduction. They did a few doses of it in this 2013 trial, and they saw I don't remember the exact percentage decrease with just 1 dose. They saw, subsequent doses. They obviously saw, a greater effect. All right, so IL-4 and IL-13 are up next, and these are 2 cytokines which are really key in maintaining a T2 high phenotype. They are sort of thought together that there's some overlapping effect of them, of both of them, although it's thought that IL-4 sort of induces the phenotype or the endotype a little bit more, and then IL-13 maintains it. They're secreted by Th2 cells as well as these innate lymphoid cells that I discussed earlier, and they lead to a lot of changes in the airways. They cause IgE switching. These cells to switch to IgE. They cause epithelial cells to produce mucus. They induce smooth muscle proliferation and collagen deposition, leading to airway remodeling. They recruit eosinophils to the airways. They cause smooth muscle hyperresponsiveness, and they lead to periostin secretion, as we talked about earlier. So both IL-4 and IL-13, as part of the receptors, share a common subunit. So if you remember, cellular receptors, they're kind of like Legos. They're modular. Like the different ones can come together to form the receptor, and this IL-4 receptor alpha is a shared subunit between both number 1, which is essentially the IL-4 only receptor, and number 2, which is a shared receptor for IL-13 and IL-4. And they both mediate their effects through STAT6. IL-13 also has its own autoregulatory receptor here, which essentially is it's like a dud. It's not attached to anything, so the cell can upregulate it, and it basically mops up extra IL-13 that's hanging around. So what anti-IL-13 agents have been looked at? Lebrikizumab and tralokinumab are 2 of them. I'm not going to really talk about tralokinumab, but we can focus on lebrikizumab. It prevents IL-13 from interacting with its receptor. So in a 2011 study with about 200 subjects, the intervention group saw increases in their FEV1 at 12 weeks, but for whatever reason that was not a durable response. When they looked at the subgroups, the high periostin group seemed to have a differential response. It responded much better than the low periostin group. And interestingly, the high FeNO group also had greater improvement. But there was no real differences in exacerbations, in symptom scores, or in albuterol use. In 2015, they came out with the results of what was intended to be phase 3 trials. These were replicate studies, loop inverse, of about 460 patients. And they were randomized to 1 of 3 doses of lebrikizumab or placebo each month. Problem was about 24 weeks into treatment on average, they found that the study drug was impure, and so they stopped giving it to people, and they just followed them out instead. So they converted back to a phase 2b. And it showed some good results. In the high periostin group, there was a good decrease in exacerbations, and there was an increase in FEV1. So it was very encouraging. Not so much for the low periostin group, but encouraging for the high periostin group. And so then this past year, their phase 3s did come out, LaVolta 1 and LaVolta 2. It's a study of about 2,150 subjects, all adults, who were on ICS and a second control. And they were randomized to 1 of 2 doses of lebrikizumab or placebo. And the effects are interesting. All right, so on the right here, we have a forest plot. The black line, I'm trying to get my marker here. The black line is the line of indifference between placebo and lebrikizumab. The red line was a pre-specified minimal clinical effect of at least a 30% reduction in exacerbations. On the left here, LaVolta 1 data is on top, LaVolta 2 is on bottom. They split the group into 2, so biomarker high and biomarker low. Biomarker high was those with a peripheral eosinophilia of greater than 300, and the high was eosinophils or periostin greater than 50. And so here's what's interesting. So in the low dose lebrikizumab group, with those with evidence of eosinophilic asthma, they saw a nice reduction, a 51% reduction in the rate of exacerbations. But in the high dose group, they only saw a 30% reduction in the rate of exacerbations, which sat right on their minimal clinical effect line. In the biomarker low group, they also saw in the low dose almost a similar 45% reduction in exacerbations. But again, the high dose only had a 28%. It didn't even meet their pre-specified minimal clinical effect. And then when you go down to LaVolta 2, well, their low dose and high dose intervention in the biomarker high group neither met the minimal clinical effect. And in the biomarker low group, it wasn't even statistically significant. It was all over the place. So really hard to interpret data like that. It doesn't show consistent results, and it doesn't show any sort of dose response. So I don't know. I saw a press release that said they were reviewing the data, but I can't imagine that. It doesn't sound like good. Doesn't sound like good results to me.
We were at one of the study sites here, and I think they're giving up on this.
I think that would be the result. I think there's a question, with these plus or minus lebrikizumab studies targeting only IL-13, I guess the question is the effect limited because you're targeting, a cytokine that has, that multiple things are acting on. So both IL-4 and IL-13, if they have overlapping effects, if you're just taking out one of them, you have IL-4, which is still mediating its sort of effect. And I guess the question is, can you target both? And with this common subunit between the two, you can go after the IL-4 receptor alpha subunit. And so that's exactly what Dupilumab does. It goes after that subunit. In phase 2 trials from 2013, they took 100 adults with peripheral eosinophilia or sputum eosinophilia, and they put them on weekly Dupilumab for 12 weeks or until an exacerbation. And this is sort of a different trial than usual. Basically, at week 4, all subjects stopped their long-acting beta agonist. And at week 6, they started tapering their steroid, and they stopped it by week 9. And the results were pretty impressive. In the Dupilumab group of the 52, although I think there was some dropout, but of the Dupilumab group, only 3 of them had exacerbations by week 12. And in the placebo group, 23 had exacerbations. And you can really see it from the Kaplan-Meier curves here. The placebo's in red, the Dupilumab's the dotted line in blue. On the vertical axis is the cumulative exacerbation rate, and on the bottom is the time. And you can see right at week 4 here, when the lab was withdrawn, the placebo group starts to have exacerbations, and by the time they come off their inhaled steroid, a good percentage, a number of them have had exacerbations. So definitely shows some promise there. We're waiting to see, so 2016, they had another phase 2 and also had pretty good results. This was a little bit bigger, 769 adults. They were on 2 different doses and 2 different sort of administration schemes, 200 to 300 milligrams every 2 or 4 weeks. And they looked at FEV1. And what was interesting here was that in those with eosinophils greater than 300, the FEV1 improved significantly by about 400 milliliters, but in the lower group, low eosinophil group, they also had improvements in their FEV1. And same thing with exacerbations. In the high eosinophil group, they reduced their exacerbations by about 75%, but in the low eosinophil group, depending on the dose, they actually had a reduction of about 60-65%. Dupilumab has also been considered in eczema. There's a few studies with adults with sort of moderate to severe eczema. It's very hard to generalize this, and I don't want to spend too much time since we're running a little late, but basically there's been some suggestion of reductions in symptom scores as well as body surface area affected by eczema with Dupilumab. The studies really aren't great. There's a lot of variation between them, and they have high dropout, about 30%. So I think that it's a little bit hard to interpret the data at this point, but with some further study, it may be interesting.
I think, Frank, didn't you just go to a meeting about this?
Yeah, they actually presented much larger studies at a European meeting, and it was impressive, is all I can say. These are like 4 out of 4 eczema patients. 70% of them had no disease. So,
and it's pretty close to approval, isn't it?
Well, I think March is the FDA.
Consideration.
Not for eczema, not for asthma.
For eczema, yeah.
And well tolerated.
Yeah, very well. So, could be the next big thing. A few other quick targets before we finish up. Prostaglandin D2, it's an arachidonic acid metabolite. It's known to attract eosinophils and cause bronchoconstriction. Vipiprant is a prostaglandin D2 receptor antagonist, and some studies that showed good decreases in sputum eosinophilia, but there was not much improvement in terms of clinical symptoms, or these symptom scores or exacerbation rates, etc. So I don't know exactly where that's going. TSLP, thiamine lymphopoietin, is an epithelial cytokine that's thought to induce the sort of Th2 phenotype. There's one study with AMG 157, it's an anti-TSLP agent. They were they had mild allergic asthma, and basically those who received it for 3 months on a challenge at day 84 had an attenuated drop in FEV1 upon inhalational challenge compared to those receiving placebo. So maybe something there. And then the last one is a novel concept. It is the study name is AZD, the study drug name. It's a non-steroidal, I think it's a small molecule that actually binds the glucocorticoid receptor like steroids do. But in animal studies, it doesn't seem to elicit the same long-term steroid effects that steroids do. And in a short study of this product inhaled versus budesonide versus placebo, they basically received it every day for 7 days, and at the end of the week, they challenged them in an inhalational challenge. Neither group had significant improvements in the acute phase response, but in the late phase response, this glucocorticoid receptor agonist had a much attenuated fall in FEV1 compared to budesonide even. So maybe something there. Obviously, I think they need to look and see whether long-term steroid effects are going to be caused by the agent. So I think in summary, asthma endotypes and their associated markers sort of remain as important as ever, especially for newer therapies. Anti-IgE and IL-5 agents remain the therapies that we have at this time, although there's definitely some promising agents on the way. Dupilumab for asthma, maybe for eczema as well, and especially for those with higher eosinophil counts, although in Dupilumab there's a lot of data to show that maybe you don't even need that high of an eosinophil count to see benefit. And I think sort of knowing the pathophysiology will help to offer additional therapeutic targets in time, offer additional markers, and offer some hope.
Potentially idiotic question from a fourth-year med student, but the earlier in your slide, if you go back to, there's a slide comparing the effect of medication in groups with low biomarkers and high biomarkers. It's earlier in that, yeah. Sort of a two-part question. First, let's say wait till you get there too. Do you know what the slide I'm talking about?
I do, yeah.
Yeah, there it is. So the first part of the question is do people with these low biomarkers and high biomarkers have the same number of exacerbations at baseline without treatment?
I would assume
yes,
so. These are coming from so this was the extra trial data. So these were people who met criteria for omalizumab. So they all had the same. Yes.
So the second question then would be
Baseline is actually on the bottom. Exacerbation rates at baseline.
Is that right?
High and low.
Okay. So they are approximately the same. So the second question is when interpreting the what's different between these two groups, is it that the cell lines themselves that are either making biomarkers or not, are they responsible for, you think, the disease, or is it a downstream effect of, like, I'm trying to figure out what the difference between the two groups are. Is it the fact that they're making biomarkers? Is that relevant then to the disease itself, or are the cells dysfunctional in the sense that they're not making these biomarkers, or is that?
What's that?
I was going to say, I don't think anybody really knows.
Yeah.
I mean, my question looking at it is are all those gray bars, are they really all the same patient? You know what I mean? And the same with the darker.
So you're saying that people with high eosinophils also have high
right.
pheno and high peroxide. Yeah, that's
right.
possible.
But I don't think anybody knows.
Yeah,
in other words, what drives those patients? Is it epithelial issues?
Yeah, I mean, one of the key things is, like, so if you're blocking IL-13, for example, everyone for a long time thought that IL-13, that's, T cell dependent asthma, et cetera. And then these recent studies show that ILC2s, which are mostly driven by epithelial, like IL-33, is actually the main source of IL-13, certainly in mouse studies, but then there's similar results in people with ILC2s as well. And so, I think from a biological standpoint, people are working their way back. So blocking IL-13 seems like it might be good. Blocking the things that are up, the key regulators of that, which are probably those epithelial-derived things like IL-33, which is in development as well, are key. And then, other things like our observations about mast cells being also, in addition to ILC2, is a key source of IL13 would be, other kind of upstream things. But yeah, I mean, it's a biomarker, but IL13 is also probably pathogenic in some ways. But maybe it's not the key thing to block.
Well, it's interesting. It shows you the failure of something like just blocking IL-13 is why it's so hard to do better than prednisone and immunotherapy, because they hit multiple targets, and to then target just one thing often fail.
Right. And the other thing, I felt like commenting on it because you kept showing that slide about the R-alpha-2, IL-13 R-alpha-2 being a non-signaling receptor. There's my colleague up in British Columbia, Del Dorscheid, he has a series of studies that show that receptor has a function as well. So things get kind of complicated once you dive into the actual biology of things. It probably is essential for epithelial wound repair. So again, kind of going back up to the top there.
Hey, DJ, periostin is definitely just a marker. There's no, right? We don't think of periostin doing in terms of asthma. Is that right, Teal, or no?
Well, I mean, there was a study on, I think people are working on that right now as far as periostin. I think it's mostly a biomarker so far, but yeah, maybe it also has some function.
It's also associated with TGF-beta signal as well.
Yeah, there was just a paper. I didn't. That's the problem with looking at a title without looking at the paper yet. But on how it affects the eosinophil function. So I don't recall what the result was. Yeah.
Well,
but, yeah.
Any other comments?
Thank you all.
Yeah. Next week, unless we've all moved to Canada.
That's because you're voting for Trump.
Ron Simon we have a guest speaker next week. Ron Simon is coming up from San Diego as our guest speaker and talking about a variety of things, partially at least aspirin-exacerbated respiratory disease, and he's a character and an enjoyable speaker.
Good session, too. Oh, okay, so you're heading over there now. Okay, cool. Yeah.
Makes so much sense that it should work, and then you give it to somebody that didn't do anything.
Yeah. You look at that thing.
These discussions we have here.
Oh yeah, no, they are. Yeah.
No, otherwise fine. That's great. Thank you.
Yeah, so I think it'd be good, I think.
Ready?
Can I introduce myself really quick?
Yeah.
Hi, I'm Gina. So I'm the new caller.
Oh, great.
So I really enjoyed your talk, and I'm a little disheveled. I rerouted myself last night because I found out you were talking and I wanted to come listen to it.
Oh,
So,
thanks.
anyway, I was wondering, would it be possible, I don't know what resources you need, but we have
Okay.
That's true.
It's like
bring him in and
we
introduce him
would-
to you just
yeah.
because he's so involved with all of the studies and everything. So I just didn't know how to contact you.
Well, email me. The other thing to do is go through Francis, who's she's like the department, department admin.
Trust me, I talked to all of the progress.
Yeah, excited some nurses.
Yeah.
This was really interesting. Also showed me my career in 10 years.
She is They don't know.
Exactly. Okay.
Yep.
Great.
And she should be able to see that. That'd be great. Thank you.
I wanted to know you up and mostly it's just that they're inverted. That doesn't, that's causing some confusion. For the most part, it doesn't. It's just that they're very prone to like sinus.
I know that they have regular tickets.
Peter.